Good morning, everyone, and a warm welcome to today's session. I am Arpita from the IGCP group, and I will be moderating this webinar today. It's purely a pleasure to have such a distinguished audience joining us for an insightful academic discussion. We are honored to welcome our expert speaker for today's session, Dr. Narsingh Verma sir, who is a Secretary General, Department of Physiology at King's George Medical University, Lucknow. He is a highly respected academician and clinician known for his significant contribution to physiology and autonomic function research. So, is a president of Asia Pacific Society of Hypertension, immediate past president of Association of Physiologists of India, immediate past president of UPDA, Secretary General of Indian Society of Hypertension and Indian Society of Crohn Medicine Treasurer of the RSSDI UP chapter. He is the director of the Southeast Asia World Hypertension League and the secretary of ACP India chapter. So today on the topic which sir will be speaking is heart rate variability, a simple window into autonomic function. Heart rate variability has emerged as a valuable non-invasive tool to assess autonomic nervous system balance with important implications in cardiovascular health, metabolic disorders, stress assessment, and overall clinical practice. This session will help us understand the physiological basis, clinical relevance, and practical application. Without any further delay, I would request Dr. Narsingh Verma, sir, to please begin with the session. Over to you, sir.
Thank you, Arpita, for inviting me for this very important talk, which I believe will help the our colleagues to understand that how the blood pressure variability can be very useful for their clinical practice and also to understand various anomalies of the cardiovascular system. So I will be talking about this. Before that, we all know that all physiological functions have a circadian pattern, and this slide is depicting this that all hormones are secreted in a circadian manner, and during daytime, during sleep time, our all physiological functions varying from the functions of the hormone and also other mechanism like uric acid, platelet function, triglyceride, lipid profile, they all have a particular pattern, and this pattern is important, and the symptoms, not only that, symptoms of all symptoms which are produced, which are there in our patients, they do have a circadian pattern. The especially gout attacks are more during the night time, and the you can see that I have given this slide that the angina and the depression, rheumatoid arthritis, allergic rhinitis, every symptom, asthma attacks, even death, all cause death is more at 6 a.m. in the morning. So time is a very important factor, and all the functions of body are related to time. And blood pressure is not a different entity. It is also varying with time, and according to time, it keep on varying. And on that matter, we define our blood pressure. During daytime, it is more, and during night time, it goes dip. And this is the those who have this dipping pattern, they are called as dippers, and those do not have the dipping pattern, they are called as non-dippers. Some of them have extreme dipping pattern, and some of them even have reverse dipping pattern. This has been seen that the dipping pattern is important, and we all know that the dipping, if it is not there, it is again a risk factor, and not having dipping is a risk factor. This has been seen. And reverse dipping pattern is very hazardous for the health, especially cardiovascular health. Blood pressure variability, what are the parameters? Blood pressure normally varies in response to physical activity, what we have daytime, and the experiencing the emotions, posture, the respiratory cycle. With each respiratory cycle, during inspiration and expiration, our blood pressure keep on varying. During the time of day, it keep on varying, which I showed you in the last slide. The food, ingestion of salt intake, caffeine intake, use of nicotine and alcohol, these all change our blood pressure pattern. Sleep deprivation is very sensitive, and it definitely change our blood pressure, and the seasonal variations are also there. During winters, blood pressure rises, and during summer it goes down. The high altitude again changes the blood pressure. The high altitude increases the blood pressure. These are some factors responsible for short-term blood pressure variability, and you see that the blood pressure can vary in the range of 20 to 60 millimeter of mercury, especially systolic one, which I'm talking about, and see the psychological stress produced by various causes at work or the public speaking. Like I am talking, the blood pressure rises the tune of 20 to 60 millimeter of mercury. Anger, conflicts, again 20 to 60 millimeter of mercury, and similar pattern is seen in the major physical exertions, including sexual intercourse and the running, lifting, and pain can have change in blood pressure in the tune of 20 to 40 millimeter of mercury systolic. Not only pain, waking from the sleep and uh, and the mid morning surge and the driving posture to the it increases, and the postural changes, the anticipation of major physical exertions, major minor physical exertions, they all have increase in blood pressure. Not only that, the medium term are these not short term, the in the terms of days to months. Short term was in the minutes to hours. So medium term, that is the days to month change in blood pressure may be because of the chronic psychological stress, that again in the range of 10 to 20 millimeter of mercury. Climate change can have the range of 20 millimeter of mercury. Intercurrent infections, this is very important. Infections can increase blood pressure or decrease blood pressure, both can happen. And increased body weight will have change in the tune of 5 to 20 millimeter of mercury, and increased alcohol intake again in the tune of 10 millimeter of mercury, similar shift work and depression. And the menstruation phases of different menstruation phases can have impact on the blood pressure, and the reduced salt intake can decrease blood pressure in the tune of 5 to 10 millimeter mercury. Dash diet has shown again the same tune, and the regular exercise can decrease blood pressure in the tune of 10 millimeter of mercury. The blood pressure variability, if you see blood pressure variability, mechanisms and the clinical relevance, the mechanisms are basically, I will deal them, but before that, relative risk reduction of fatal events and combined fatal and non-fatal events in patients on active antihypertensive treatment. This is very important, and we know that both systolic diastolic blood pressure can be shown to have the impact on the mortality, all cause mortality, cardiovascular mortality, non-cardiovascular mortality, fatal and non-fatal events. Everywhere, this is important to manage blood pressure. And similarly, the blood pressure variability, what is it? It is, but we know that the rather than expressing a background noise or a phenomena occurring at random, these variations are known to be the result of complex interaction between extrinsic environment and behavioral factors and intrinsic cardiovascular regulatory mechanism, which are very important. They can be neural, central, neural reflex, or the humoral influences, and they are not yet completely understood. Parati has done a lot of work. He is my good friend, and we are working together. We have worked together in the World Hypertension League. Parati has done some very good work, and he has published this. And you can see a recent article, not very recent, but 2013 article, which review article shows all these changes. Then the variability subtypes, if we talk about, there can be short-term blood pressure variability within 24 hours, but it's very short-term beat-to-beat variability can be there, or the short within 24-hour period, and that can be minute-to-minute variability, hour-to-hour variability, and day-to-night variability. So short-term variability can be minute-to-minute, pulse-to-pulse, and it can be hour-to-hour, or it can be day-to-night variability. While the long-term variability varies from day to day and visit to visit variability, which is again very important when you are treating a patient of hypertension. The visit to visit variability becomes very important because that is the only variability which a physician can encounter while he's measuring blood pressure in every visit when patient is visiting to him. And the seasonal variability I have already addressed. So first we talk about blood pressure variability mechanisms. And the mechanisms of the short-term variability, which includes beat to beat, and this is because of the baroreceptor activity. This baroreceptor activity is very sensitive, and according to the baroreceptors, keep on firing the impulses, and this rate of firing of impulses by the baroreceptors can change our blood pressure, which we do. And while we are teaching MBBS students in physiology lab, and we do the postural changes, we observe these postural changes, and where we see the effect of baroreceptors. Then the respiration. Respiration do have a change, which I talked about, the inspiration and expiration. This cycle will have impact on blood pressure, and the sleep is very important. Sleep reduces blood pressure, but not all the phases of sleep we talk about. That is the particularly deep sleep, we reduce blood pressure, but there are certain phases of sleep where the blood pressure rises, not goes down. Chemoreceptors are again very important. So mechanisms basically is central and reflex autonomic modulation and reduced arterial compliance. This is very important. And humoral effects, the rheologic factors and the emotional factors, the behavioral influences and physiological activity, sleep, and the postural changes, they are responsible for short-term blood pressure variability. This short-term blood pressure variability is very important. And then the this is beat to beat and baroreceptors that I have already talked about, and the when we talk the short-term blood pressure variability, this becomes very important, and this variability is known and natural characteristic of blood pressure curve, and the blood pressure variability is secondary to mechanism of varied nature, and which I have already talked about, and it is divided into short term and the long term. So short term we have talked, and now I will talk about long term variability. Before that, you can see the different prognostic importance of the nocturnal blood pressure fall and the short term blood pressure variability. Before I talk about long term, the short term blood pressure variability, you see here that the 24-hour intra-arterial blood pressure, the if the variability is less and the blood pressure variability is there, and this is within range, it is protective in nature. But when it goes out of range, it becomes damaging. So variability is all the physiological, but when this variability becomes more, it is damaging. And the this damage can be known by assessing blood pressure variability. We can assess it by different indices, by standard deviation and the coefficient of variation, day to highest BP changes, and the other average real residual blood pressure variability. So these are the various methods by which we can know the blood pressure variability, and we can assess it and find out what are those patients where the variability is more and those who have high risk. This can be by the CV, which is very important, and the this is the standard deviation of blood pressure into the coefficient of variation into 100, and the residual blood pressure variability, fast fluctuating fluctuations that remain after the exclusion of the slower components of the 24-hour profile, and this can be known by this particular formula, and this is very important. By this we can find out this residual blood pressure variability, which is for a long time, will become a lot of risk factor. Day to night by dipping pattern, which is very easily can be known by using the ABPM devices, and the night to day again by the ABPM or home monitoring devices. The circadian variability, we can find it out, and by that we can divide our patients on dippers, non-dippers, which I have already talked about, reverse dippers, and excessive dippers, and this can find out their risk of developing cardiovascular diseases. This nocturnal dipping status, as I mentioned, is very important, and the mechanisms for this are because of the persistence of the sympathetic drive even at night, which should go down during night time, and reducing the sensibility of the baroreceptors at night. The baroreceptor should be more sensible, but the sensibility reduces, and that causes the change in the blood pressure pattern. The volume overload in specific conditions of heart failure can also be one reason, and autonomic dysfunction, which is more common in diabetic individuals. Though nocturnal dipping status is good, and the non-dipping status is associated with CV risk, and the nocturnal BP independently have predicting the outcome. So nocturnal hypertension becomes more important in relation to daytime BP, and that is why we want to know all these variability. Morning surge is a double-edged sword. This is physiological process. It is there, but when the surge is more or less, that can produce more risk for the cardiovascular disease, and that can be known by using the ABPM, and it has been found to have relationship with target organ damage, and all target organ are responsible for that. So the we can know this by showing different pattern during morning time and during the night time, during daytime. Find out the morning surge. You can see by this that the morning BP is the highest BP, and this surge defines the stress and defines the cardiovascular risk. That is why 24 ABPM is important. By that we can know this very well. So this is the clinical relevance of 24-hour BP variability. I'm not talking only theory. You can see a lot of work has been done, and the design had been cross-sectional to longitudinal studies in rats and human beings. The longitudinal studies and the cross-sectional studies by various authors started from 1987 to even 2014. You can see here that the Parathi has done a great job, and that has shown the endpoints of target organ damage to all-cause death, and to LV mass, to CV mortality, to stroke, everything we can relate with blood pressure variability. That is why we are talking about it. This again shows relationship between the 24-hour BP variability and organ damage in hypertension. So again, this is very important to know. Relationship between the risk of stroke and the morning BP surge in the Osama study. Osama study in Japan by the study has shown us that the why this variability is more important in relation to stroke, and here the number of patients were around 1,500. So, again, the prognostic value of the ambulatory and the home blood pressure monitoring has shown us that when we do, then we can find it out the risk better, and we can treat the patients, and we can avoid the catastrophe of stroke and heart failure and even other cardiovascular diseases. So that was the prognostic importance and clinical relevance of long-term blood pressure variability. Now I talk about, and here this slide is very important. You can see that the ventilation can produce the short-term blood pressure variability, and the central sympathetic drive and the increased sympathetic drive and decreased arterial or cardiopulmonary reflex humoral rheological factors, they are responsible for very short-term blood pressure variability from beat to beat, and this is related to subclinical organ damage and the increased cardiovascular events and the mortality and increased renal outcome as well. So this is known that the even very short-term blood pressure variability is important. Then comes the short-term blood pressure variability. This is here again the increased subclinical organ damage and the cardiovascular events and the cardiovascular mortality, all cause mortality, all factors have the significance, and even EGFR progression goes down with this. So this is basically because of arterial compliance, and then comes the midterm variability, and again you see how day-to-day variability is important, and then comes the long-term variability. Here subclinical organ damage up to EGFR and the seasonal changes. So all type of variability has relationship with the mortality and the morbidity. Target for research, how we can utilize this knowledge even better, and this has been done by which drug can reduce the blood pressure variability better, and it has been found that amlodipine working 24 hours has a significant change, and this addresses blood pressure variability better. So, does treatment induce reduction in blood pressure variability? This is my own job, own work we have done, and here we have find that the if we produce variability by giving drug therapeutic uh, change, and the variability if the uh, in the night time dipping pattern is not there, and we produce therapeutic dipping by giving drug in the evening, even that is working, and we have some good relation with that by reducing albuminuria and also addressing autonomic dysfunction. So pharmacological dipping can also help us. Then the need of additional studies are there, because this is not enough, and we need more studies. So, where the studies which we have today and what we need can be known by this slide. Average BP levels and blood pressure variability both are important. Short term, long term, mainly short term is important, but long term is also important. Which measure blood pressure variability? Standard deviation is the best one, and relationship with the physiological variables like endothelial function and the SpO2, arterial, they are important, and arterial stiffness is important, and some the correlations exist between that. And we do not know whether the blood pressure variability alone can stratify risk. We need more knowledge on this, more research on this. And we can conclude that the drug induced reduction in blood pressure variability recommended accompanied by a reduction in the event rate, we do not know. Although I have one publication in this that shows that the albuminuria goes down, but long-term results are required. Do different drug classes have a different effect on blood pressure variability on outcome. Probably CCBs are better, and the long acting ARBs are also better. But we have data with CCBs only. Long term ARBs we do not have data, but probably they will be better. And is there enough evidence to consider blood pressure variability as a new target for treatment? Probably yes, but we need more data for that. So 24-hour BP values more closely related to target organ damage and future events than office reading, which is very important, and higher 24-hour BP variability, higher CV risk, that is known. Long-term lasting CCBs are better to address blood pressure variability, and prospective outcome studies needed to confirm that treatment-induced reduction in blood pressure variability also working. Although I show that I this is method by which I do ABPM at my clinic, at my center, at my research center. Here you can see this is 7 day monitoring of blood pressure, and 24 hours 7 day monitoring is shown here. You can see this is the systolic blood pressure, the red one, and the this blue one is the diastolic blood pressure, and the heart rate is shown here. And you can see here in this particular graph which belongs to uh, and you can see here that the variability is there. Not only that, it is also showing at what time maximum variability was there. That is called as acrophase. So this is how we record 24-hour 7 day blood pressure and find out the variability. Uh, by this method, if the blood pressure is more than 135/85 millimeter mercury, we take this reading normal in ABPM, and by that we can diagnose morning hypertension, or we can diagnose daytime hypertension, or we can diagnose nocturnal hypertension. So this is very important, and various mechanisms are known for it. And we can also find out nighttime dipping, and the nighttime surge can also be find out, which is very very dangerous. And the not only that, the ABPM and home monitoring are method by which this variability can be find out easily. These are some studies which have published in the nursing women and the other shift workers, and the blood pressure variability has been shown, and how the risk reduction is there. And we have also proposed that how we can find out the variability and we can address it for better outcome of the patients. So these are some research which have been published. I'm not going in detail of it. You can find it out all on ResearchGate. So with this, I will like to end here, and thank you all for giving me time. And now I'm here for your questions if they are there. Thank you. Thank you very much.
Thank you, sir. Thank you so much for the lucid presentation. I think sir is facing some network issue. We'll try to connect with him, and once he's back, we'll address the questions that have come from audience. I would request everyone to please stay with us. I think sir is facing some issues, which he will resolve and will join back. There are many questions that we have received from our doctors and which are very practical. So let us wait for sir to join in and then we can start. Okay, yeah, sir is here. Sir,
Yeah.
kindly switch
Again.
on your camera, please.
Yeah. Yeah. voice?
Yes, sir, I
I
can
think
hear you.
कैमरा ऑन करने पर बंद हो जा रहा है.
No problem, sir. Then no problem. हम लोग ऐसे कंटिन्यू करते हैं.
Yeah.
Okay. Sir,
You
the
can
first
put the
question
question.
is in routine clinical practice, how can the heart rate variability be used as a practical tool to assess the autonomic dysfunction in patients with common condition like diabetes, hypertension, or CAD?
It's a very good question. For a common person who is using, who is practicing physician, the best method is home BP monitoring. Home BP monitoring done in the morning hours and in the late night hours before sleep can give a better idea of blood pressure variability, especially the short-term blood pressure variability. But for to know more detail, one need the ABPM. But for a practitioner, home monitoring is a better option. By that, most of our knowledge will be there and we can know the blood pressure variability better.
Thank you so much, sir. The next question is also very practical. So, what are the common misinterpretation of HRV that clinicians should be cautious about while applying it in their clinical decision making?
Because the blood pressure variability and heart rate variability is subject to various behavioral changes. So one should be very cautious while analyzing data. A single data or a bout of data is not enough. We require 24 hours. That is why I'm saying ABPM is better. But if we know the behavioral changes and we can correlate them, then we can find out why the heart rate variability was more at that particular time. And heart rate variability is good for health, it is not bad. Only blood pressure variability is bad. HRV is there to take care of blood pressure variability, and if HRV is there, heart rate variability is there, it is a good sign. And in autonomic dysfunction, what happens? The parasympathetic uh, tone is lost, and then the sympathetic also. So we have the heart rate variability reduced in different pathological conditions. One should be aware of that.
Thank you, sir. One more question is there. So, in day to day practice, how can HRV be used to moderate response to lifestyle intervention like exercise, weight loss, stress management, or sleep optimization?
Yeah, this is a very good question. In common medical practice, one should go for the resting heart rate. If there is a resting tachycardia, that shows that parasympathetic dysfunction in autonomic nervous system has occurred, which is very common in a long-standing diabetic patient. So, if a resting heart rate, resting after 5 minutes, resting heart rate should be recorded for at least 1 minute. And if the resting tachycardia is there, that is showing that probably autonomic dysfunction is there. Need not to go for very sophisticated instruments, only resting tachycardia is enough. And when the sympathetic nervous system is also gone, the patient will have resting bradycardia. That is very dangerous. And these patients will have almost the transplanted heart, almost totally autonomic nervous system control is gone, and that is very dangerous. So even the just monitoring heart rate in the resting condition, and when this has been done and we ask patient to go for a mild exercise and there's abrupt rise in heart rate, that again shows that patient is having high risk of developing cardiovascular disease. And sleep and the nutrition and physical activity, these are the three parameters which can have an impact on the cardiovascular risk. And sleep, at least 7 hours good sleep is required to reduce the cardiovascular risk. And that during sleep time, if the heart rate and blood pressure variability is known, then we can predict a lot of things.
Thank you so much, sir. Sir, I think there is one more question which is also very important. Let us
Yeah,
take this, sir, with your permission.
yeah, yeah.
So this question is how should clinicians interpret HRV changes in patient on medication like beta blocker or antihypertensive or any antidepressant?
Again, very important practical question. Uh, One should take the heart rate for that, and that is enough, especially when we are using CCBs. and short acting CCBs like nifedipine. Nifedipine or any short-acting CCB will produce reflex tachycardia, and that is bad for the heart. So one should be very, very cautious. One should not use the short-term CCB. One should use long-term CCB like amlodipine and the nifedipine, the sustained release, or even the cilnidipine or the benidipine or elizapine. Like these drugs will have less changes in the heart rate variability, and the reflex tachycardia will not be there. So we should monitor heart rate, especially when we are using the CCBs, short term CCBs, and beta blockers. Beta blockers, when the heart rate is less than 50, one should be cautious using beta blockers. But usually, beta blockers are given to reduce heart rate when the reflex tachycardia is there, or the tachycardia is there, sinus tachycardia is there. So, by monitoring the heart rate, one should decide the dose of the beta blockers and CCBs.
Right, sir. Thank you so much, sir. I will not take much of your time and we'd like to conclude our session for today. Thank you so much, sir, for the enlightening talk, and thank you so much for answering all the queries that have come from our audience.
Thank
And
you,
I would
Arpita ji.
thank you
Thank you.
so much, sir. Thank you once again. And thanks to all the audience for putting up the questions. This make the session more engaging. Thank you.
Yeah,
Thank you all for attending the session. We are concluding the session for today. Thank
thank
you
you.
all. Have a good day ahead.